Hello, my name's Andrew Hartle. I'm a consultant anaesthetist in the Major Trauma Centre at St Mary's Hospital in London, and I'm a Professor of Practice of Anaesthesia at Imperial College London. And I'm going to talk to you now about anaesthesia for war zones. During the talk I'm going to cover a range of different settings, talk about some of the general principles of trauma anaesthesia for those of anaesthetists that don't deal with this in their daily lives, discuss how austere medicine principles differ from the normal practice of medicine, and then discuss some of the specific issues related to anaesthesia in austere and war zone conditions, specifically the facilities, drugs and supplies, and other considerations. So the first thing to say that this is not a cookbook, that what I'm going to talk about in this talk are the general principles. They're not rules, they're guidance to allow you to apply the knowledge you already have so that you can do the best with what you have for the patient in front of you and for those patients still waiting for your care. Now, ideally, one would never be doing things for the very first time in a war situation, but you may have had no time to prepare for this, and you must always be guided by doing the best for the people that you're caring for. And one of the principal uncertainties of war is uncertainty, and you should expect things to change from hour to hour, from day to day. And so being flexible in what you do is important. Now, essentially what I'm going to talk about is a hierarchy of trauma care, starting with the basic principles of the treatment of major trauma, which we do every day. And that expands in civilian lifetime, in civilian practice, in the case of major incidents when there's a sudden influx of major trauma patients that may temporarily overwhelm a hospital or healthcare settings. But that usually lasts only a matter of hours, and there is a very rapid response and the capacity to envelop that. And then in civilian settings, there are disasters, often related to natural disasters, flooding, earthquakes, rarely man-made disasters, which again is a sudden overwhelming event, but from which a relatively rapid recovery and relief is expected. There is the particular circumstance of military anaesthesia and limited military conflict, and I'm not really going to talk about that because that exists very rarely and has very specific training and expectations of the people involved. What we're really going to talk about in this talk is generalised war affecting a principally civilian system, so military style trauma inflicted in a civilian setting. So let's talk about the general principles of trauma anaesthesia, and my assumption is that most of you have some experience of trauma, and I suspect many of you have got considerably more experience of trauma anaesthesia in recent days. So what are the basic principles? Well, the basic principles are still the ABCs of anaesthesia. If you've got air going in and out, blood going round and round, and either the patient or the bit of the patient you're operating on is asleep or numb, then you're ahead of the game. But then let's narrow that down a little bit. So a lot of the problems related to trauma anaesthesia are those related to hypovolemia, and for most non-head injury cases, a mean arterial pressure of between 60 and 65 millimetres of mercury or a systolic pressure of 80 millimetres of mercury is more than adequate for the general conduct of anaesthesia, certainly until control of bleeding has been obtained. And don't target blood pressures greater than 60 to 65 MAP or systolics of 80 unless you've got a very convincing reason to do that. For example, in the setting of a traumatic brain injury. Most people will do perfectly adequately with saturations of 95 to 98%, and in fact our recent experience of COVID would suggest that actually many people will tolerate saturations in the low 90s without coming to any great harm. And so effort spent in trying to achieve higher saturations is wasting your time and effort and potentially using oxygen that you don't otherwise need to use. one of the biggest killers in trauma is hypothermia. It's easy to cause and very difficult to treat, and a particular problem in the setting of austere, disaster or war zone anaesthesia, as patients may present after a prolonged extrication or transfer to a medical facility, and may have already established hypothermia before they arrive. And the aim should be to achieve a temperature of greater than 36 degrees centigrade or 97 degrees Fahrenheit. Second slide, general principles of trauma anaesthesia. At the end of surgery, a haemoglobin of 80 grams per decilitre is acceptable in most patients, but any significant bleeding should be treated with blood whenever possible, and one should avoid crystalloids or colloids or anything else that generally dilutes the blood volume. Haemoglobin concentrations in real time on blood tests always lags behind the clinical picture and can be falsely reassuring. Patients who were normal before they were injured, who present with a haemoglobin of less than 12, are 3 times more likely to require a massive transfusion within the first 24 hours than those patients who have preserved their haemoglobin. And a haemoglobin of less than 10 on presentation makes this very likely to happen. And beware acute anemia. Most shock in trauma is hypovolemic shock. It's usually too early for sepsis or inflammatory response syndrome to cause hypotension in the first couple of hours, although I've said if patients have had delayed extrication, delayed transfer to a medical facility, or have got or have got grossly contaminated wounds, then that sepsis may be more likely. Neurogenic shock is possible in spinal injury patients, but not uncommon, and in the setting of austerity and war zone anaesthesia is associated with a very poor outcome. Hypovolemic shock and vasopressors do not mix, except as a very short-term temporising measure whilst blood is being delivered. But the use of vasopressors in hypovolemia can significantly increase the mortality. So let's start with a patient. First of all is assessing the patient and having a structured approach to assessing the patient. Get as much information about the patient as you can as quickly as you can, and the at-missed approach is helpful. Knowing the patient's age, time since injury, the mechanism of injury, what injuries have been seen or suspected, what the patient's symptoms and vital signs were on presentation, and most recently, are they stable, are they deteriorating, and what treatment has been given so far and what treatment recommendations are there. If possible, speak to the individual patients themselves. Take a very concise medical history from the patient, not relying just on the information you've been given, and use the ample approach. Do they have any allergies? Do they normally take any medications? Is there any significant past medical history, particularly that, and including there the possibility of pregnancy? In a civilian war zone, significant numbers of patients will be women of childbearing age. When did they last eat or drink? And what's their description and recollection of the events leading to admission? Because once you've put this patient to sleep, once you've induced anaesthesia, it's too late to go back to check. And these are the key things not to remember. So ample presentation. Do you have any other information available? Do you have any blood results? A venous blood gas is usually more than adequate if you have access to it and quick. In most patients, if their saturations are normal, there's no need for an immediate arterial blood gas, which may be painful, take some time, and actually may make life difficult for you if you're planning to use an arterial line. Patients with significant thoracic trauma will probably need an arterial line, so you may as well put one in when you can. And that will allow sampling intraoperatively. But consider, do you have access to the equipment to put an arterial line in? Can you monitor the arterial blood pressure if you do that? And do you have access to laboratory facilities to actually measure those samples? So having assessed the patient, it's now time to plan your anaesthetic for the surgery that's planned, and a quick WHO checklist or brief with your surgical colleagues and the rest of the theatre team is essential. Just take a minute to discuss what the surgical plan is and your plan, and explain, make sure the whole team knows what you're planning to do, and that includes any particular positioning requirements and any lines that you need to put in. That 1 minute spent before you start will save you 15 minutes later if you anticipate what you need and your surgical colleague needs, and it stops you getting in the way and trying to do things at the same time. 30 minutes into this sort of surgery, you should be having a snap brief, and the only exception should be if there's ongoing active bleeding that the surgeon is not able to control by manual pressure. We'll talk about that shortly. What are the aims of the checklist? Well, we're doing different things here. The surgeons are going to fix what's broken. They're going to fix the anatomy. And in the meantime, it's our job as the anaesthetist to fix the physiology. But we need to understand what we're doing and to make sure that what we're actually doing doesn't interfere with each other. Checklists are to be encouraged. They stop you forgetting things in the heat of the moment, and using them is a sign of strength, not a sign of weakness. And none of us can remember everything all the time. So if in doubt, go back to a basic checklist to see what you're missing. So you know your patient, you know the plan. Ideally, before you start, you should know your team. But very often in these circumstances, you may be thrown together with people that you don't normally work with. So try if you can to know who's who. It's helpful if you're working with strangers to have names of the people, or at least what their job is, because actually people can all look the same. Know exactly who's who, what they can do, what their background and experience is. Do they have any other skills, and who else is around? Can they squeeze a bag for you? Can they give blood for you? Can they give drugs? Can they put IV lines in? And if there are times when you're not operating, when you're not resuscitating or treating patients, take every opportunity, apart from getting to eat and sleep and rest, to talk things through. Talk through the cases you've been through. Plan for the cases that are coming up. If you get the opportunity to simulate and plan what you would do for unusual circumstances, then do it. Any time spent in preparation is well spent and will stand you in good stead. So let's talk to some other specific considerations. So temperature. Patients get cold really fast, as I've already said, and hypothermia is one of the big killers in trauma. Warming is difficult. If you can get the room temperature as high as possible, so if you're still working in an intact civilian facility and everything is still working, get those rooms warm and keep the rooms warm, even if it's uncomfortable for you. If you haven't got dedicated warming systems, commercially available warming systems, warm the fluids however you can. At the worst, you can shove bags of blood or fluid up under your arms before you give them to try and warm them up. Or you can try and warm them in bowls of water, which you can keep topped up from wherever you can get hot water from if you've got a supply. But try and keep patients as warm as you can. Minimise their exposure, maximise their warming. If you've got forced air systems, use them. If you've got fluid warmers, use them. If you've only got warm blankets, use them, but use whatever you have. Then the environment, and we'll talk about this a little bit more later on. You need to be able to see to operate and to anaesthetise, but you need to balance that against the tactical risk of light giving away your position, depending on the circumstances in which you're operating. Always try and keep a head torch to hand in case the power is cut off, or you have to turn off the main lights for the safety of your team. Have a plan for what's needed for each individual case. Position it as close as possible before you start, so that you're not having to go off to get things or send people off to go and get things, and then you can reach it. If you've got the time to invest in having cue cards or index cards of the stuff that you need, what kit you need for particular operations, what drugs you need, particularly because you may be working with staff that you don't work with normally, then invest in that time. Have a system for keeping track of the bloods and fluids you've given. That could be as simple as a piece of paper with a tally written on it, an area on the floor for empty bags, or a whiteboard, but try and keep track of what fluids you've given, and particularly what blood products you've given, to try and guide your transfusion and assess actually how successful your surgery and anaesthesia are. Positioning. The cruciform position is generally the best compromise. It gives you access to the head for the airway, the arms for drips and tubes, and the head and neck for either chest drains for central lines. And having the arms outstretched also tends to maintain the difference between anaesthetic and surgical areas and keeps the surgeons away from your important tubes and lines. If you're going to put a subclavian line in, then you'll need to put that in before you put the arms out on boards, or just put one arm out and be putting the subclavian line in on the other side. Having the arms out in crucifix also allows the surgeon to make a prompt to start, because you can continue to put other lines in, for example IV access or arterial lines, whilst the surgeon is operating as well. So consider the crucifix position as perhaps your go-to position, but that will have to vary depending on the nature of the injuries and what surgery you're planning. So now you're going to start your anaesthetic. What are the principles of induction? Well, where possible, you should resuscitate before induction of anaesthesia. And this means giving blood or fluids for patients who present hypotensive. But as I've said earlier on, a systolic of around 80 to 85 is sufficient, and you should not delay induction of anaesthesia and surgery, and it's the surgery that will be life-saving in active bleeding, or if you can't hit the target because of ongoing bleeding. What that patient needs is someone to stop the bleeding. If a patient has significant hypotension before induction, there's a very real risk that they'll have a cardiac arrest, or at least significantly worsening hypotension on induction of anaesthesia. All the anaesthetic agents will cause a degree of vasodilatation and a low blood pressure, and positive pressure ventilation will exacerbate any hypovolemia. So anticipate that patients will drop their blood pressures on induction of anaesthesia, and be prepared for that. What anaesthetic agents should you use? Well, you may not have any choice. You may only have the agents that are in your cupboard. But if you have any choice for trauma, then ketamine is almost certainly the best induction agent. For patients who've got a normal, intact central nervous system and have a GCS of 15, then the intravenous dose is 1 to 2 milligrams per kilogram. For patients who are already unconscious or significantly obtunded, that can be reduced to 0.3 to 0.5 milligrams per kilogram. And the use of ketamine is not contraindicated. It is safe in patients with head injuries. If you have a patient with an isolated head injury that requires surgery, then thiopentone is probably the best agent for that. It's the second best agent for other trauma. In a neurologically intact patient, the dose is 3 milligrams per kilogram. And if they're unconscious or obtunded, then that can be reduced to 1 to 2 milligrams per kilogram. In acutely hypovolemic patients, propofol is probably the least preferred agent. But if it's all you have, that's what you have. But try to reduce the dose you need by the use of high-dose opiates such as fentanyl, so that you can use less propofol for induction of anaesthesia. If you're going to intubate, and you will do for most of these patients, then rocuronium is probably the ideal agent for damage control, rapid sequence induction, a dose of 1 milligram per kilogram. However, its availability may be limited because it has a very temperature-related shelf life and normally needs to be kept in the fridge. If you don't have rocuronium, then vecuronium can be used as a higher dose of 0.2 milligrams per kilogram for rapid sequence induction, and because it's kept in a powder form, it's easier to store and doesn't need refrigeration. Once you've intubated the patient, then set your 30-minute alarm for your first snap brief with the surgeon, so that you don't get caught up and lose track of your circumstances. So for maintenance of anaesthesia, for the sick and actively bleeding patient, the best approach is to use boluses of IV fentanyl whilst resuscitating, and maintain whatever volatile agent you have at a 0.3 to 0.5 MAC of volatile agent, so up to about 1% of sevoflurane in young fit patients. As you resuscitate them, as their blood pressure hits 90 millimeters of mercury, give another 100 micrograms of fentanyl. You can expect the blood pressure to drop as the patient vasodilates, and then fill again with blood and products until the pressure comes back up to 90 to 100 millimeters of mercury, and repeat as required. Keep giving those fentanyl boluses until the bleeding is controlled and the patient is more stable. And what you're aiming to achieve is analgesia and amnesia with minimal peripheral vasoconstriction. And vasoconstriction leads to hypoperfusion and acidosis. So you want a vasodilated, warm-filled patient. And in acute trauma, you may need 3 milligrams, 3,000 micrograms of fentanyl for this process. As part of maintenance, you want to minimise your use of oxygen and volatiles, because oxygen and power become really scarce resources in an austere or war zone environment. So preserve them where possible, and if you've got the option of going to low flow of oxygen and other gases, then please do so. There is a total intravenous anaesthesia infusion regime for damage control surgery, first described by Restel over 30 years ago, where you take 200 milligrams of ketamine, 5 milligrams of midazolam, 2 milligrams of vecuronium, and make that up to a syringe worth of 50 mils, and then you infuse that in mils per hour at half the patient's body weight. So a 70 kilogram patient would get 35 mils an hour. It gives approximately 2 milligrams per kilogram per hour of ketamine and works quite well, particularly in young fit patients, if there are minimal other options. But again, this is something that ideally you would have tried beforehand, but if that's the only equipment you've got available, and the reference is here on the slide. So I talked earlier about the snap brief 30 minutes in. It's easy for the anaesthetist and the surgeon to lose track of what's going on in very, very difficult and busy surgery. For damage control surgery, you should be limiting the operative time for 90 minutes from skin to skin, and not be trying to undertake definitive procedures. And it's really important to set an alarm every 30 minutes so that you and the surgeon have a few moments just to stop and listen and talk to each other, so you can decide whether you're winning or not and what the next best plan is, and is it time to stop surgery and continue resuscitation. So what should happen in this snap brief? Well, the anaesthetic brief should be, it is now 30 minutes or 60 minutes or 90 minutes since we started operating. The blood pressure is currently X, and it is getting better, it is getting worse, or it is stable. I have given this much blood and products. The current pH and acid-base balance and other results, if you have them, are as follows, and the patient's temperature is. So a very, very brief, focused summary. The surgeon should be updating you on what they found, what their current plan is, and how long they think it's going to take. And then between the two of you, you need to agree whether you can continue the procedure or whether you need to move into a damage control mode or go into a definitive procedure mode, and what the next steps are. And you need to repeat this every 30 minutes so that you both maintain situational awareness and maintain that shared decision-making process. Coming now to the end of the surgery, you're going to have some other decisions to make. And the first question is, am I going to wake this patient up? And if you are, have I reversed the muscle relaxants? Bearing in mind you may have given a big dose of muscle relaxant at the beginning, and if they're cold, muscle relaxation will take longer. If they're acidotic, muscle relaxation will take longer to recover. And you need to, of course, have the drugs available to reverse that relaxation. Are there any other drugs present that will impair consciousness? Can they breathe okay? Is their gas exchange okay? And basically, are they on less than 60% oxygen with a PO2 greater than 11? Have they got enough analgesia on board? Is their pH reasonable, ideally with a pH greater than 7.2? And are they warm enough? So ideally a temperature greater than 36. If yes to all of the above, then you should try and wake them up and send them to the appropriate ward or observation area. If the answer to any of those questions is no, then you're going to need to consider ongoing resuscitation care in either an intensive care unit or post-operative recovery area, or whatever facilities are available to you. And if those facilities aren't available to you and you can't get the tube out, then you may need to make arrangements to transfer that patient elsewhere if that's possible. The decision about whether to wake somebody up or not should not come as a surprise at the end of the procedure, because you should have a pretty good idea of how well they've responded and behaved in response to both your anaesthetic interventions and to surgery. And always try to be thinking about 30 minutes ahead. So as well as keeping people alive and warm, part and parcel of trauma care is massive transfusion management. And so major trauma leads to this triad of hypothermia, coagulopathy and acidosis. But then the massive transfusion can, if not done properly, lead to hypokalemia, coagulopathy and hypocalcemia. So it's really important to stay on top of both the blood and necessary products. So here are some rules of thumb. You should be checking the ionised calcium, if possible, every 30 minutes via a blood gas whilst you're giving ongoing blood product resuscitation. If you can't measure the ionised calcium, then as a rule of thumb, give 10 mils of calcium chloride or 20 mils of calcium gluconate for every 4 units of blood. In a military setting, people would aim for a ratio of 1 unit of red blood cells and 1 unit of plasma or FFP. 1 to 2 may be what's achievable, but you should give what you've got. And that will obviously depend on your resources and your circumstances at the time. You're unlikely to get platelets unless you're using a live donor panel. Citrate in blood and plasma preservatives leaches calcium out of plasma and leads to worsening hypocalcemia and coagulopathy and bleeding. So keep replacing the calcium. And of course, calcium is a positive inotrope, so it may help with the blood pressure if you're really struggling. And here on the left here is the other things to remember to do in the setting of major hemorrhage. Don't forget tranexamic acid, ongoing resuscitation, keeping patients warm. If they're not stable and you can't control the bleeding, consider damage control surgery, correct metabolic derangement. Avoid vasoconstrictors except in extremis because they double mortality. Check for clotting regularly if you can. Repeat imaging if you still have access to imaging, and consider interventional radiology if that's still an option, and calcium, as I've said. So you need to know your system, and this is when you're planning. You need to know what drugs you're likely to need, what drugs are available, and you need to know what the dynamic situation is. What's in short supply? What's going to be needed? Am I going to have to change my anaesthetic plan? Don't routinely draw up emergency drugs just in case if you're in a resource limited setting, because once they're drawn up, they've got a very limited shelf life and you don't want to be throwing away drugs that you haven't used. Do I know what the availability of blood and blood products are? What are my transfusion triggers going to be? Is there a maximum amount of blood that's available for this patient or for all the patients I've got? And is that going to limit either who I anaesthetise or how I anaesthetise them? What are the facilities for care at the end of this surgery? So assuming that you get to the end of the operation, can I wake him up? Where can I send him? What are the capacities of the recovery, of the ICU or the wards? Do those wards know what patients are coming? What equipment do I need? What equipment is available? And if equipment isn't available, is it going to affect my plan or the surgeons? What are the other key points for trauma anaesthesia? If a patient is unstable and you're not getting control of the blood pressure or the clotting, then you need to move into damage control surgery mode, where all the aim of the surgeon is to control hemorrhage, control air leaks, restore the vascular supply, and decontaminate or prevent further decontamination. And if you're in damage control mode and the surgeon is doing something else that isn't one of those things, then you may need to step in and discuss what the surgical priorities are. Every bleeding trauma patient should get a gram of tranexamic acid if they present within 4 hours of injury, and then, if possible, an infusion of 1 gram over 8 hours. But the most important thing is to get that initial bolus in. For paediatric patients, the dose of tranexamic acid is the same as it is for paracetamol or Tylenol, so it's 15 milligrams per kilogram. Watch out if you've got contaminated wounds, because the basic principles of surgical decontamination may involve vast amounts of fluid and wash, and if that's not warmed, you can cool down a patient very quickly, and hypothermia is very much a killer in trauma patients. And beware patients who are needing vascular shunts or having vascular supply resupplied, because when the vasculature is re-established, you're going to get a sudden rush of cold acidotic blood with lots of potassium. Consider before the patient releases the inflow, giving calcium and a fluid bolus, and you can expect significant hypotension. And it may be that as the vascular supply is resupplied, that you need to do a stage reperfusion where you allow blood flow for 10 seconds and then put the clamps back on. Then you deal with the hypotension, the metabolic derangement, and then repeat when stable, and just keep doing limited reperfusion until the clamps can come off without causing hypotension. So that, very briefly, is the principles of trauma anesthesia and major trauma management as we would manage them every day in a major trauma centre in civilian practice. But now we want to talk about the specific issues of delivering that sort of anaesthesia in a war zone or disaster setting. So what are the general principles of austerity? Well, austerity principles in anaesthesia, it's the difference between acceptable versus normal and the gold standard. Now, in day-to-day civilian practice, we would always aspire to the gold standard, but the enemy of good enough is perfection, and you won't achieve perfection in a disaster or a war zone. And you really will need to be satisfied with just being good enough, not just for this patient, but for the next patient that comes on. And if you were to try and achieve perfection for one patient, you'll use a lot of time and resources for very little additional benefit, but at potentially much greater cost to other patients. So this is a time to accept good enough, and establishing just what that balance is, it will be one of the challenges of working in this setting. But the opportunity cost of a massive intervention in one patient could mean that one or two other patients may not have the chance to get treated. So you just need to do the best you can. This isn't how we normally practice. Most of us are not used to having to make compromise, and most of us will go to extremes to save individual patients, and that may not be a luxury that we have. You will inevitably second guess yourself after these difficult cases, and this is normal, and it will take a lot of time to let go of that, but time will be the healer. There will inevitably be resource issues that are beyond your control. You need to think about that in advance and have agreed with your team how you're going to manage them and what are your ceilings of care and input for certain patients, and that will be a dynamic situation depending on the nature of and frequency and severity of injuries and the setting and resources available to you. And now the brutal reality: some patients will die, many of whom would have died even in a first world fully staffed major trauma centre. Most of them would have died if you hadn't delivered the care you have. And you should focus on those that you can reasonably save, and not those who are probably beyond your ability to help. This graph taken from a BJA article demonstrates one of the key differences between disasters and conflicts. So in this graph that we see that with a natural disaster there's an initial peak of patients presenting to hospitals or to medical facilities over time, and then that quite quickly falls away with a couple of subsequent peaks which relate to people living and working in a setting where the natural infrastructure is being destroyed, and then people presenting with other conditions that don't go away, like obstetrics and paediatrics and infectious disease and heart attacks. Whereas in a conflict, the first peak may not be the biggest peak, and then there will be repeated peaks of varying frequency and intensity without an apparent end in sight. So in a disaster, you get this sudden big peak, relatively short duration, with the expectation of relief from your neighbours nationally, regionally or internationally, whereas in a war zone there may be no obvious end in sight. The intensity may vary. During a war zone, you're going to have direct military or combat casualties, so the direct ballistic effects of firearms, weapons, explosions. There will be the secondary effects of collapsing buildings, fires, and lack of infrastructure, and then at the same time, people will continue to go into labour and have obstetric-related needs for medical intervention and surgical intervention. Children will be injured in all of these settings, and so anaesthetists who don't normally practice obstetrics or paediatrics may end up treating both those groups of patients. And ultimately, then there is the risk of chemical, biological, radiological and nuclear injuries in war zone, which is beyond the scope of this brief talk. Let's talk about some of the specific issues that you may have to face if the circumstances get particularly difficult. So the first one is oxygen, which is not normally something we think twice about, although at times during COVID supplies got a little short. But supplies will be very limited. So the infrastructure of hospitals may be damaged by enemy action, and it will be extremely difficult for oxygen to be delivered either as liquid oxygen or oxygen, seeing as they're both heavy and they're both very dangerous in a war setting. So oxygen supplies may be very, very limited. Modern anaesthesia workstations depend on a continuous supply of high flow oxygen and air, and although many of them will have an alternative supply of oxygen, they don't work as well. And it's important for you to understand how the anaesthesia machines that you have will work with limited or no oxygen. Although oxygen concentrators are available, they tend to deliver quite low pressure flow, often only suitable for draw-over anaesthesia if available, and relatively few civilian anaesthetists have access to draw-over equipment and any experience of doing so. Remember that actually young, fit patients may tolerate room air anaesthesia if you have a mechanism of delivering it, but oxygen may quite quickly become one of your very limited resources. Similarly with electric power, most hospitals will have standby generators, but those generators, if the mains power is interrupted, which happens quite early on and unpredictably in disasters and war zones. However, standby generators can themselves be damaged and will often have a time-limited duration before they need stocking up, usually on diesel, and the supply of fuel may be limited. Anaesthesia workstations will have a limited backup supply for the acute power failure, but will not run for long without a power supply. And the same is true for the standards of monitoring syringe drivers and pumps, ventilators, all the things that we're used to, and even the lighting that's necessary just to see to work. So keep everything charged for as long as you can. Have a plan for how you're going to do things without power. Remember, you can run many infusions through burettes or by hand, but you need to have thought about how you would do that, what drugs you would use and what concentrations are available. And we'll talk about some of the personal preparation you can do a little later. Most modern ventilators need oxygen, air and power. There are ventilators that were available years ago that you could hand crank, but I haven't seen any of those available for many years. In the absence of electrical power or gas-powered ventilators, it is entirely possible to ventilate people by hand. If you don't have electricity, you can just squeeze the bag or an anaesthetic machine, but you can also ventilate by hand using a self-inflating bag, using a non-rebreathing valve, and you can create your own anaesthetic circuit with ventilator tubing. And of course, you can use assistance to squeeze that bag. It's very primitive, it's not very controlled, and if you don't have electric powered monitoring, you may not know what the patient's CO2 is like, but you can ventilate people by hand, use assistance in those circumstances where people have had to ventilate by hand for a long time. One of the earliest problems is that people get pressure sores and blisters on their hands, so almost anybody can squeeze a bag. It doesn't have to be the anaesthetist. If you don't have access to ventilators, consider using spontaneous ventilation for as long as you can. It gives the added advantage of being able to use depth and rate of respiration as an additional physiological monitor. If you want to administer PEEP, then you can create PEEP valves just by using ventilator tubing in the expiratory limb and putting it into a bucket of water, and the depth of tubing under the water gives you the amount of PEEP you're delivering in centimetres of water. So what other anaesthetic techniques are going to be available in this resource poor setting? You may be able to use local anaesthetic or regional anaesthesia. It avoids the need for general anaesthesia and avoids the need for a lot of the monitoring that you might require. Nowadays it can be highly effective, particularly with the use of either nerve stimulators or ultrasound if you have those skills. But again, you need to have the equipment, they need to have the batteries in them, you need to know how they work, and you need to have the consumables. So they need equipment and training and ongoing power for ultrasound. But one of the potential advantages may be, particularly if the availability of anaesthetists is a problem in your institution, that once you've established a regional block, if the patient is stable, then the intraoperative care of that patient could be potentially delegated, allowing an anaesthetist to supervise more than one patient. And you may want to consider that if anaesthetists are a shortage specialty, that one anaesthetist may be supervising more patients intraoperatively, directly supervising the induction and wake up of patients, but delegating the intraoperative management to others. Spinal anaesthetics are familiar to most people. They're simple, they use small amounts of drug with potentially less need for oxygen with the right patient selection. They can be used for almost all procedures below the umbilicus, and of course they're very useful in obstetrics, but they're particularly unforgiving in patients who have hypovolemia and patients who need careful selection and resuscitation. And of course it is difficult to maintain the sterile technique that we'd be familiar with in particularly austere settings, particularly if you start operating outside of clinical or hospital environments. And as well as all the issues of delivering healthcare and the limited clinical resources, you need, of course, to think about yourselves and the things that you need to look after yourself, and that it's worth having to hand at all times. I've mentioned before the difficulty with power and light, and so having immediate access to a head torch and spare batteries can be really important. You may need both medical PPE, scrubs, hats, face mask, eye protection, and you may need to consider, depending on your setting, whether you need additional war zone PPE, the use of helmets or body armour, depending on your particular circumstances and the location of your facility. Make sure you've got your own personal medication, because you don't want you to become unwell in the middle of this, because you're a really vital resource. And then the basic stuff: have scissors, have a bougie, have marker pens, because you're probably not going to have little stickers for your syringes. Have a marker pen both to write on patients if needs be, and to write on syringes what's in them. And have your pockets full of sticky tape. Consider having your own paediatric circuit. An AST piece often go missing, so if you've got access to those, that's really helpful. So in this brief whistle-stop tour through trauma anaesthesia, where possible, do what you know best. This is not the time to try things for the first time, unless you have to, in which case do the best you can. Get to know your team and use them as best you can. They may have skills that they don't normally use, which come into their own. Be aware of how resources are different from normal, what's limited, and how things are changing, and tailor your anaesthetic techniques to the equipment that's available to you. Expect things to go wrong and expect to need to carry on afterwards. You will learn incredibly quickly, and I suspect many of you already know much more about war zone anaesthesia than I ever will. and it's possible that you'll give me the next lecture on how to do this. And in conclusion, all I can say is I wish you the very best of luck.